we'd give you sort of an in-clinic look at it. She has a lot of course, case studies, but we grabbed 3 because I wanted to show you on that. And fortunately or unfortunately, the 3 I grabbed, none of them are concussion, which is okay because concussion, although sports get a lot of claim to fame, the difficulty is motor vehicle accident. So 3.8 million incidences, accidents, concussions with sports, and yet motor vehicle accident, it doubled to triple that. So one of the things I want to do is give you some little bit of base with it. So in the therapy, when you see that we do therapy, once again, therapy is along the lines of time. If they're acute, 0 to say 3 days, 0 to 7. So we have a timeline that we can do certain types of therapy. So I want to quickly just say that once again, if we have, just like Dr. Quaid was talking about, metabolically. So if we're seeing these patients, and I get the opportunity to see these patients early on, so I might see a patient and they still got grass stains on their knees from the sports. So I will see a patient 0 to 3 days. I'll see a patient 0 to 7 days, something in that line. If we do, of course, their therapy is going to be a little bit different than if I'm seeing them later on. And once again, if I'm seeing them and they're early, they're in acute phase, and I call acute anywhere between probably 0 to 10 days, I'm going to first set them up to get them out of symptoms. And then I'm going to start the therapy accordingly as they can adjust to it. And then if someone comes to me that's over, say, 30 days, it's going to be a little different system. If they come to me after about 2 years, I'm going to be a little bit more aggressive. So what happens is I do a matrix type of therapy. So that patient may come in, and depending upon what kind of therapy they need, what's going to end up happening is I might see them one time twice a week. I might see them every day for 12 to 15 days in a row, including the weekends, depending upon what kind of therapy they need. So I do have a matrix program, so people who come to me from a long distance away and their nervous system can handle it. I will probably even see them once to twice to 3 times a day for a 5-day, for 10-day, for 15-day, depending upon what they can do. Because what we're doing is we're doing an assessment, we're testing, and then we're reassessing. And so we're always trying to be cognizant of that nervous system. And right eye is one of the tools that I use to know whether or not I'm moving in the right direction. I can do my exam, I can look at eyes, I've been doing this for a long time, but what happens is that maybe those subtle nuances that I can't quite 100% predict that they're going to be there. Or the other thing is that I've really got to convince that patient, that guardian, that individual, that this person has something going on and it's more than what they think. And so some of this, I think I have one patient that was seen by 4 different physicians, both ophthalmology, neurology, and some of my colleagues, and told that they were okay. And that they didn't need any glasses, they didn't need any type of assistance, they're 20/20 and they're fine. So I know we hear that story all the time, but what happens is we were able to do something very simple to convince mom and dad that this individual needed some care. And once again, oh, I'm sorry, yep, thank you, I'm sorry. So once again, I gave some information. So this particular patient, and I apologize, is 49 years of age and had a concussion, came to me approximately in 2 years. I just saw this patient not too long ago. And what ends up happening is that for 2 years when it initially happened, of course they gave her the standard of care as rest. And then they just said she saw her physician quite often. She saw a neurologist, saw an ophthalmologist, and they all said, you got 20/20 vision, you're normal. And pretty much by the time she came to me, she had a baseball hat on. She was ashen, losing weight, just didn't feel good, didn't even know if she wanted to be there, but this was her last part because she needed to go see a psych. They were sending her to a psych eval. And so she was beside herself on what she wanted to do. So we did our eval, and so when you see, I did it side by side, so give you a little bit of warning. When I saw her, the first thing I'm doing after I do my exam and figure out where some things are at, I ask her how she's sleeping. And when they say I'm only sleeping about 1 or 2 hours a night, the very first thing I have to do is get them sleeping. And whether or not we're using something like an element called calm in a glass of water and drinking at night 20 minutes before they go to bed, or we're having them do something like entrainment, to help settle them in, or mindfulness or something like that to get them sleeping, but we're going to do something. And sometimes I'm not opposed to medication, although some of the medications out there like Ambien actually work against my therapy, but we got to try and figure out. I usually talk with the physician about melatonin. I'll talk to them about, 92% of Americans are deficient in omega-3, 83% of Americans are deficient in vitamin D3. Those two also facilitate not sleeping, so sometimes we start to talk to them about that. So this is this patient, of course, when she came in, and her original, as Melissa was showing you, is that she's just following a circle. And once again, I'm talking to her about some things, and she's telling me, her long story, which why wouldn't she? She's had to put up with it a long time. All I did was show her the circles. I said, do you remember looking at something that should have been a circle? And I said, and this is what you're seeing. And she broke down and cried for 10 minutes. She goes, finally, somebody believes me. And so what happened then is, as we're looking at this information, and what Melissa was talking about is the horizontal, what ends up happening a little bit is the horizontal movements, or any movements, is that we want to have every neurological possibility. And so what happens is, if I'm going to reach for this podium over here corner, and then suddenly I change my mind and go for the pitcher of water, I'm able to do that because I'm not neurologically compromised. And so what happens is, after a concussion, traumatic brain injury, or stroke, what happens is I no longer have that automaticity. I no longer have every neurological possibility that I can do and then switch them on a dime. What ends up happening, I have to think about it, think about it, think about it. I don't want to go there, but all of a sudden I can't remember where I really wanted to go. Oh yeah, a glass of water. So what ends up happening in the horizontal pursuits, is that we have the horizontal wanting to be in that movement, to be stimulated, and yet we have those downward intrusions, and that's because the eye wants to go up or down. So it's not, so what happens is that you have the omnipause neurons, and you have the burst neurons, and you have everything all charged up, or you have some things that are being quiet, and what ends up happening is, as they're trying to do the excursion across the page, they have these intrusions because the omnipause neurons and the burst neurons in the brain stem generator are not working correctly. Okay? So these are all these intrusions, and so after our therapy, to a certain point, she is certainly not anywhere where I would stop therapy, but she is now able to drive. I didn't recognize her when she came back in when we were doing therapy, because her hair was washed, she didn't wear a cap, she had makeup on, she felt completely different, and actually she had to come up to me and tell me who she was. I did not recognize her.